We are like,
A very warm welcome to everyone present here. Today we are here for the AIOS IOC 2024, the topic being minimally invasive glaucoma surgery. Is it here to stay? Without any further ado, I welcome the chairperson, Dr. Venkatesh Rangaraj, and our moderator for today's session, Dr. Sushmita. We have a lot of talks lined up for today's session, and may I now request Dr. Sushmita to take over for the further proceedings.
Yeah, thank you, Dr. Saurabh, and a warm welcome to everybody. We have a lineup of mixed stalwarts from across the globe, and we are very happy to be hosting them for this virtual session. And I request Dr. Venkatesh to give an overview of MIGS and what it's all about, and then we'll go on to the main talks.
Thank you, Dr. Sushmita. I think it's a great session we are going to have today on behalf of the International Ophthalmic Conclave. We have some very good panelists and also speakers who are going to share why MIGS is going to stay, not now, even for a longer period. I have my colleagues who have a very good experience as panelists, Dr. Ganesh and Dr. Swati, and we have Dr. Sunita Dubey from New Delhi. She is with the Shroff Charity Eye Hospital with a very good experience doing complex glaucoma surgeries, including MIGS. We have Professor Konrad Schragel from the King Khalid Hospital, and also one of young aspiring MIGS surgeon from Johns Hopkins, Dr. Jitin. So these are my panelists, and we have also some terrific talks today, including Dr. Leon AU from UK. He's got very good experience in dealing both complex cataracts, corneal problems, and also glaucoma. He does a lot of trials in MIGS. And unfortunately, Devinder will not be joining, but he has a recorded talk to share with us because he's traveling somewhere. We have a very senior surgeon from India, Dr. Vanita Pathakre, who's got, again, a terrific experience in doing MIGS, to share with her experience about using iStent. And we'll have Professor Konrad speaking to us update about Hydrus and a few other procedures. And we also have another very innovative MIGS surgeon, Dr. Craig Chaya from US again, sharing his experience on when he does MIGS for different kinds of procedure, including open angle, angle closure, and in secondary glaucomas. I request Dr. Sushmita to take it forward. Madam, you're muted.
So I think we'll kickstart with Dr. Leon. Hello, Leon. Good to have you on the show again.
Hello.
So we're waiting for your talk, and fire away.
I think you can all see it. Yeah, thank you very much indeed for the invite. I'll try to keep it to 10 minutes if I can, because MIGS nowadays is such a huge topic. So it's really good to kick off in terms of these phenomenal questions in terms of why do we need to learn MIGS? It's a very good question because even 12 years, 13 years in, I think this is still being challenged and debated across the globe. I work with most of the companies, so you can say that I am fair in that way, that I buy my drinks from every single pub. But glaucoma has always been, and probably still for a lot of you, in terms of that's all we decide in surgery, whether we're going to trab or not to trab. It's been the case when I was in training, and in many parts of the world, many clinics, that's probably still the case. And I've certainly had a mentor that tells me that if you don't need a trab, I don't care what you do. And I think those days are gone. I think trabeculectomy is very good. Let's set off with the right foot that I'm very pro trabeculectomy. There's nothing that beats it in many ways. It's very good for advanced glaucoma. It's a sight-saving operations. But just because you don't need a trap, it doesn't mean that we don't need any surgical intervention that may benefit patients. These are benefits that I think previously we ignored. Trabeculectomy is very good, but is it really something that you want to do if someone who's just got ocular hypertension being uncontrolled? Is this something you really want to do just because the patient can't really use the drops or they're intolerant to every single glaucoma drops there is, but not that much glaucoma? And I see really that good in combination with dealing with cataract surgery. And I would say that for those three indications, it's not really that great. It's a big hammer to crack a small nut. And we've always wanted something else to go for those patients. And in terms of evaluating nowadays what is best choice for surgery, while in the past we only have one or two, then we can ignore every other benefits that there should be. But nowadays, of course, we would measure our surgery in terms of the lowest IOP. That may be your best choice, the lowest IOP. And you may want to choose an operation because it's got the highest success, and it doesn't necessarily mean it's got the lowest IOP. It may get down to 10, but only 50% of the time. That's not a high success. You may want to choose an operation because it's the lowest complication, and that certainly hasn't been the case for some of the traditional surgery. Of course, we always say that we want things to last. Glaucoma is a lifelong disease, but bearing in mind the life expectancy and a lot of our patients, when you come to deal with them in the 70s, having 20 years lasting is not necessarily the case for a lot of our glaucoma patients who are elderly. And on the right-hand side, these are the aspects of glaucoma surgery that I think we've kind of ignored in terms of getting the best vision. There's never really been a big deal in a glaucoma clinic. My fellow always comes in and say, your trap's looking great, pressure is 10. And I always say, what's the vision? They say, I don't know. I've not really looked at it, because we're so focused on pressure. With the workload, and I've been to India, I've been to Shashmita's place, and I've seen your workload. You want something low maintenance. You can't be bothered seeing them every single week to fine-tune your trabeculectomy if you can do something else. Cost is a major issue across the globe, whether being in the UK, being in India, anywhere, cost is an issue. We want something fast. No one wants to spend 2 hours crafting the perfect operation. There are too many patients. And the most important thing is universal results. There's no point saying that the expert can deliver great results. We want everybody across the globe, my trainee, everybody can deliver the same result, which means something needs to be pretty straightforward. We're searching for the Holy Grail, and we definitely don't have it, but that drives us all to carry on looking at new things. And I think we should carry on looking at that. There are loads and loads of MIGS nowadays. When I first started, we had one. It was an easy talk. Nowadays, you can run a 3-day symposium. I'm mostly going to talk about the ab internal, which is what we're here to talk about. And you've got great lineup of speakers covering all the aspects anyway. But a lot of it is all down to restoring physiology. And I think that's point number one, that we should restore physiology. We are now at an era where primary SLT is the way to go, because we want to restore physiology. The more we understand about the meshwork and the outflow, the more we are going to tackle this problem at the physiological level, at least to begin with at the earlier onset of the disease. So we know how it drains, but we're beginning to know more and more about meshwork. Not only the meshwork is not a dead piece of filter, it appears to be an active tissue that has contractile cells, that actins that allow us to contract to increase permeability. There are not only this mythical Schlemm's canal that may be segmented, there are collector channels, but we're beginning to see connections between the trabecular meshwork and the collector channels. There are little ropes and fibers that seem to connect. So then what we do to the canal nowadays may change as we understand and image these better. And the fluid seems to flow radially out of the eye and not necessarily go around a 360 canal per se. The MIGS first kicked off for me around about 2009 with the Glaukos iStent, and Glaukos is still going strong. This is the original iStent, the smallest device, which is basically a titanium bypass. It bypasses the trabecular meshwork, and it goes through the meshwork into Schlemm's canal, allow us access to the Schlemm's canal that hopefully the aqueous can flow out easier, reducing the juxtacanalicular meshwork resistance. The iStent has evolved, and we're going to have a lovely talk about 1 stent versus 2 stents versus 3 stents. This is when we first started back in the early 2010. That was all the rages. Do we put 1? Do we put 2? Do we put 3? Glaukos has since moved on to the Inject, which is much more user-friendly. I'm particularly fond of the Inject W, which I think the improvement with the bigger flange has given us a better precision in terms of placing the device. And the Infinite is now in the US and is about to come, which is basically injecting 3 iStents to allow 3 access points. And I think there is a huge debate about access versus size. And I think that will be something for a different talk probably. Of course, in terms of size, we have the Hydrus, which I've been fond of and I've been an investigator for the last 10 years. It's a bigger device. Conrad's going to tell you about it. We cannulate the Schlemm's canal. The idea that we dilate the canal, we keep it open, we have a bigger access point. It's like putting a big cannula in your vein rather than as multiple small cannula, which is what the iStent is. And the fight between the iStent and Hydrus will continue, and we're going to hear from our speakers. But I do want to show this, although I'm not supposed to cover the iStent or the Hydrus. But when we're gonna hear the talk about 1 versus 2 versus 3 iStent, and I think this is what iStent Infinite is going to offer us. This is 3 iStent Inject W, 1 in the middle, and then the other 2 either side. I'm going to span them out as wide as I could. And the concept being that we have access. Now we want access point. You don't know where the collector channels are. There's a bit of a hit and miss. So we're going to space out. We're going to 3 access point as wide as we can. And then watch the top bit of the vessels as the irrigation, as the viscoelastic get removed. You see how the vessels blanch away. It's amazing when you see 6 clock hours of vessels being blanched away when you got 3 access point of an iStent Inject W. And then the coolest thing is that when you flush Vision Blue into it, you now see all the vessels lighting up right across 6 clock hours. When we talk about restoring physiology, this is when you tap into your collector channels. This is what you see. The blues are collector channels. The wiggly red one are the veins that contains blood. To be able to see that, that is the number 1 point why you want to do mixed, is to be able to actually see these collector channels. I'm going to show a second video. Conrad will show you more. This is a Hydrus. So if you believe size matters, then you go for a bigger device. It is smaller quadrants in terms of that, yeah, you got 2-3 clock hours, 2-3 hours, I think, top. While if you're going to go for 3, iStent, you are going for 6 clock hours essentially. But it's a bigger device, and this is what we see. Again, this is a big Hydrus that's gone into an angle that's big enough to take it. Now watch the vessels at the top as I pressurize the eyes. Watch it, and boom, it goes. Literally, the fluid flushed down, and you see this amazing blanch that happens. We have restore physiology with access anatomy that is only appear in textbook and plasticine cast. And watch it when you put some Vision Blue into it. It literally blew my mind. And that is why I kind of do what I do. And when you see the vessels lighting up, that's where the aqueous is flowing into. Now we have restored or even enhanced potentially physiology by bypassing meshwork. Just look at how they light up. It's absolutely phenomenal when you see that. We've got other ways of doing it that we may not be talking about today. We have the Omni, which is a device that cannulate the Schlemm's canal, dilate it with viscoelastic, and you can rip it if you want to. And we're going to hear the talk about ripping the meshwork, and there'll be debate about whether you rip or whether you stent, and then which camp do you sit in and how you're going to use them. The last talk will probably hopefully give us some idea in terms of how you choose in what patients. So Omni is quite a clever, clean little device. And then we can use it for, we can also have a fiber optics to dilate the canal. This is a canuloplasty that you can shoot the fiber optic through. We've got suprachoroidal device I'm not going to show you. But ultimately, I think for a cataract glaucoma problem, as a combined procedure, then MIGS comes in pretty well. It's a quick, low-risk add-on. It gives you a mid-pressure and significantly reduce your medication. And it provides you still the phaco recovery that we need without people losing vision. Conrad and so forth will cover all the FDA trial. We have the evidence to show you adding a device adds value on top of phaco alone, even in narrow angle patients. That is sometimes worth putting a device in, although PAS remains a bit of an issue. But when you look at some of the systematic review, then phaco GSL plus agonial surgery gives you more bang for bucks in terms of lowering pressure than phaco alone. So for me, even narrow angle is worth having some mixed surgery. They offer you modest pressure lowering, but it reduces medication burden. Even EGS guidelines state that. It reduces medication count and is hugely important nowadays. We don't really want to see patients with eyes like this anymore because you know that the impact of that on your trabecular meshwork surgery, on your trab, basically. You are burning your bridges. If you have patients on that many medication, your trab ain't going to work very well. So anything to reduce medication load for me is great. I don't even know why we're debating MIGS nowadays. We have data to show you that if you add a MIGS device, you are less likely to need subsequent glaucoma surgery. So it's a bit like taking an aspirin to prevent a heart attack. I don't really see there should be an argument about it. We've got data to show your visual fields progression seems to be less if you add a device. And I'm going to finish off with the iStent paper, which is lovely that this is the first time we see a MIGS device in a pivotal trial that improves quality of life. So this shows you that the VFQ-25 scoring was better when you've had a MIGS device. Your ocular surface index is better when you have a MIGS device. And this is the sort of things that improve the biggest impact, believe it or not, was driving. Patient reported they feel better in their driving ability when they have a MIGS added to the phaco. Not just because of vision improvement. This is phaco iStent versus phaco alone. So we even have quality of life improvement when you add a MIGS. So why wouldn't you learn it? Thank you.
Thank you, Leon. That was a lovely overview. A quick question to you. SLT versus MIGS, you mentioned ocular hypertension.
Yeah, I don't have any doubt that SLT is very, very good. So I would probably never put them head to head. If you can do an SLT, do an SLT, without doubt. So if you failed an SLT, then, or when you're coming in for cataract surgery, that's where MIGS comes in. I don't think there's ever really a debate. SLT for me would always be.
Would you do it if you didn't have to do a cataract in a clear lens?
What, you mean MIGS?
Yes.
I think standalone MIGS surgery is a whole different game. Data is sparse and success is a bit hit and miss. So I'm not 100% sure I do many standalone MIGS. And you may want to rip the meshwork more when it comes to standalone surgery. This is anecdotal.
Okay, thank you. Dr. Venkatesh, I'll take you on to introduce Dr. Davinder.
Yeah, so Dr. Davindran is from Texas, and he has been a great innovator in MIGS, and he has come up with a brilliant technique called gonioscopy-assisted transluminal trabeculotomy, wherein you insert a catheter ab interno and do a 360-degree trabeculotomy. And more importantly, that technique has been of great support, especially in developing world, when you can bring down the cost by using a phioprolene suture, and which has become a very popular technique now across the developing world, including India. And many of our surgeons have mastered the technique and have been training a lot of people to do, especially in patients who have even moderate to little advanced glaucoma, where there is a very good intraocular pressure control. And today we will have his talk, which is a recorded talk on and sharing his experience on these techniques.
Dr. Subhav, can we have Dr. Devinder's talk, please? Is Dr. Subhav online? Dr. Subhav Prasad? I don't think he's online.
Should we come back later for his talk?
Yeah, I guess so. I guess we can move on to Dr. Vanita's then. Yeah. So Dr. Vanita Pathak Ray is, of course, one of the foremost MIGS surgeons in India, and she will build upon Dr. Leon's talk and talk about when she would do 1, 2, or 3 procedures. Dr. Vanita, please, are you ready with your talk?
Yes, I am. Can you hear me?
Yes.
Thank you very much. Thank you for this kind invite. Thank you for your kind introduction. And I thank IOC to think about me where MIGS is concerned. So my job has actually been made very easy. I was wondering how I would fit so many things in 10 minutes. But basically, these are my disclosures. So I actually want to step back a little bit, and this is an aneurysm if you've not done neurosurgery. Ever wondered why clippings are a lot less compared to coilings? Or have you ever wondered that if a stent can be placed in the heart, 2, sometimes even 3, then open heart surgery can be avoided? This is what a cath lab looks like nowadays in cardiac surgery. Why go so far? What about ophthalmology itself? Large incisions have given way to the really small ones with very savvy phaco machines, also the uber expensive maybe femtolaser cataract surgery with very high-end lenses that are put in patients' eyes, and patients are demanding more and more. So why are minimally invasive procedures preferred is because of the faster operating time, high safety profile, very rapid recovery, and improved quality of life. And this is so important from the patient's point of view. Therefore, even despite the cost, they prefer it. Open surgery will always remain a fallback, especially in advanced cases, in all the examples that I have given you. But why should glaucoma be deprived of its innovations? So like Leon, I would say, why are we even debating? Is it here to stay? Of course it is. It bridges the gap between the less invasive to the highly invasive surgeries that are available in glaucoma, and it fulfills all those criterion of minimally invasive surgery. And I keep repeating, it is patient centric, and it is this point which we should also be giving a lot of importance: rapid recovery with improved quality of life. So he's talked about the iStent, the generation 1, which looked like a snorkel, the snorkel in the AC and the long pipe in the Schlemm's canal. This gave way to the iStent inject, the second generation, which had a head, a thorax, and a flange. The flange was slightly smaller than the entire length. So the modification that came now after this is the iStent W. W has a flange which is almost equal to its, or is equal to its length if you look at it. And then 3 iStent inject Ws combined to form the iStent Infinite. Actually, the number of iStents are not infinite. Number of iStents are 3. Infinite is the number of clicks. And believe me, it is the clicks that can sometimes cause nervousness, surgeon nervousness at the time of surgery. So the infinite clicks really do help. Just briefly, G1 specifications, it's about 1 millimeter in length. And when it came out, it was the smallest device. Of course, now the iStent Inject is the smallest device, 1 millimeter in length and 0.3 millimeter in height. On the other hand, the G2, about 340, 60 in length, and 230 is the width. And 2, of course, come on 1 injector. G1, only 1 came on 1 injecting device, or, probe. So the W, therefore, has, a length equal to its width. And this is a massive improvement on the iStent Inject, as it helps over implantation. And just have a look at what G1 action was. It was parallel, almost parallel to the trabecular meshwork, whereas G2 and W goes in perpendicular to the trabecular meshwork. And the same thing translated in real life. This is, in fact, the very first G1 or iStent done in India. Unfortunately, many years after Leon did it. He said 2009. This was 2021. And you can see only one device is comes preloaded with one device. And as soon as it is in the Schlemm's canal, you can see a regurgitation of blood, which is a very good sign. You can use some viscoelastic to see that the stent is placed in good position in the eye. Here's iStent Inject, which we still don't have the Infinite in India, but iStent Inject, where you use the perpendicular motion, you inject the device in the trabecular meshwork, so it's such that the head and the thorax sits in the Schlemm's canal. And here too, this was slightly underimplanted, so you see we pushing in place, and then you see a little bit of blood coming from the Schlemm's canal, regurgitation. And this is a little bit of an oops moment in iStent Inject W. It shot off way before I actually was close to the trabecular meshwork. So I had to explant it, I had to rethread it, and then, of course, implant it again, which is actually fairly simple to do. But maybe it was a bit too close to each other. Here in iStent Inject Infinite, you actually use at least 6 clock hours. So we know a few things now with studies being done that it helps to open up dormant collector channels, especially in the infranasal area. It is limited by the episcleral venous pressure, and so therefore very low target IOPs cannot be achieved. Therefore, possibly it is only effective in early disease, mild to moderate, and that remains its major indication. An open angle is mandatory. So if you have an closed angle, you will have to do a goniosynovitis. But of course, you also worry about pus formation later. It is overwhelmingly safe when compared to traditional blood-forming surgery. IOP spike being the commonest complications. You can get transient hyphema over and under implantation, as you saw there, and blockage in the postoperative period. So Alex Huang did a very elegant aqueous angiography study, and before implantation, you can see that there's very little collector channels to be seen, whereas once 2 have been implanted, and those are indicated by the red arrows, you can see a network of the opening up of the channels. Kevin Gilman, too, did a very elegant study with ASOCT about a year after implanting them. One section was directly over each iStent Inject, and one section was 500 microns away, with one section being on the temporal limbus. And what they found was there was a 75% increase in the diameter of the Schlemm's canal next to the iStent Inject, and about 46% at the opposite limbus. And this was, of course, compared to controls, as you see there. So the ideal candidate, if you ask me, for MIGS, when you combine it with cataract surgery, and all the regulations are for a combination with cataract surgery other than Infinite, which has been granted regulatory approvals for standalone. So these are patients where you have mild to moderate glaucoma, and we're not talking about Infinite just yet. Open angle, IOP either controlled on 2 to 4 on undergoing cataract surgery, of course, or they may be uncontrolled on medication, inability to take or intolerant to anti-glaucoma medication. You saw many photographs by Leon. And of course, significant ocular surface disease. We underestimate the amount of ocular disease that happens in glaucoma patients on anti-glaucoma medication. It is in excess of 50%. And of course, allergies to anti-glaucoma medication. So the global experience of iStent Inject has been over 15 plus years, with over 1 million devices and over 250 publications, and a few of them here. iStent Inject with or without phaco, follow-up of at least 6 months, you can see that there has been a universal reduction in intraocular pressure and a fair amount of reduction in the medication as well, except for one study there. So what can you expect? You can expect a moderate drop of 20 to 35% and at least a 70% medication reduction. This is at 5-year, and this is Henger et al. Study. So that was mostly with phacos. What about standalone? People have been doing standalone G1 and G2. And at 5 years, you can see a more than 30% reduction and reduction in medication, with a very small percentage actually needing any further surgery. Now, the premise of three devices really comes from, I think, stems from this study, which talks about long-term reduction with three iStent devices. These are G1 that have been put, and you can see when 3 stents were put in, the pressure was much lower than when only one iStent was used. And medication-wise also, you can see over a period of time, the eyes on one iStent had more number of, required more medication than the other two groups, 2 stents and 3. So based on 20 plus years of data and more than 20,000 eyes being studied, the pivotal trial of Infinite had a cohort which had 2+ average of 2+ failed prior surgeries, mean medication 3.2 and mean IOP 23.5 when they started. And what they found was about 92% actually either maintained their medication or it was reduced, and they got a greater than 27% reduction in IOP, with more than 73% getting reduction, more greater than equal to 20%, and about 47% getting more than 30%. I'll just briefly take you through a case study of mine. This is actually the first case, and he received G1, history of mild POAG, but he had a trabeculectomy and multiple needlings, which failed. And he was ultimately on 5 topical medications over the 5 years after his failed surgeries. He developed severe intolerance, and his IOP was 22 in the right eye with 5 medications, and 29 in the left eye with 3 medications, and he was mild. This is how his eye looked. He was constantly complaining of red, teary, watery eyes. Once I washed out the drugs, this is how he looked. He underwent a phaco stent in September 2021 in his right eye, and January 22 in his left eye. It was the very first one, as I told you. And post-operatively, I happened to give him a trifocal lens, and so he's unaided 6.6 and 6 with more than 2-year follow-up, 17 pressure on the right side, equating to 22% reduction in IOP with 2 medications, so 60% reduction in the medication, and reduction in the right eye, in the left eye, close to 38%, and all medications were stopped. And this is how he looked after his phaco eye stent surgery. And just as a reminder, how he looked before the surgery. So I just briefly show you my results. These are unpublished results. I plan to publish them. A group of eye stent and inject together with a follow-up of over a year. I got about a 20% reduction in IOP and more than 86% reduction in AGM. Now, I have also looked at the 2 groups separately, but here I have also included much less follow-up. And you can see that more or less in both the groups, we have about a 20% reduction and greater than 80% of IOP and greater than 80% reduction in medication. So why to intervene early? I love to answer this question. I like to reset the AGM clock for a patient. It improves the quality of life. What do we mean by AGM clock? If you reduce or if you eliminate, great. They're not on medication for at least a few months to a few years. And reduction also helps improving their quality of life. It has excellent safety profile, and controlled glaucoma, you get additional IOP reduction as well. And there is a very low reoperation rate. In fact, in all the eye stents I have done, I have only reoperated in one eye. So MIGS has brought about a change in the paradigm of surgical management of glaucoma, with eye stents being the smallest devices, which help to bypass the trabecular resistance and improve facility of outflow. It is safe and efficacious. And G1 and G2 mostly indicated in open angle glaucoma, mild to moderate, whereas iStent Infinite has expanded. They talk about interventional glaucoma surgery now. May be useful in failed surgeries. It's very patient-centric, not only because of safer, lesser number of post-op visits and early visual rehabilitation, but also reduction in glaucoma medication has several advantages. eliminates issues of non-compliance and non-adherence, a phenomenon that happens worldwide. It decreases recurring cost of the anti-glaucoma medication. And of course, all of this improves quality of life. Therefore, I personally believe that the option of MIGS should be given to all glaucoma patients who are undergoing cataract surgery. And unfortunately, we all know, and Leon has alluded to this, cost may be a limiting factor. Thank you very much for a patient here.
Thank you. Thank you, Dr. Vanitha. Do we have the tech team here? I mean, can you share?
Yes, sir. Should I play?
Yes, you can play Grover's presentation.
Hi, I'm Devinder Grover. I'd like to thank the AIOS for inviting me to speak today. I'm going to speak today on angle surgery, just some general tricks and tips for angle surgery, and then get into
Can you
some
increase the volume a little bit?
on
Tech team?
surgeries, goniotomies, and for GAT. These are my disclosures, but I do work with a lot of the companies in this space, but these are my own thoughts and my own opinions. I'm going to first start off with an overview of my surgical algorithm, discuss some basic tips for just beginning angle surgery. So just as an overview, when I talk to patients about what I'm going to do when I perform angle surgery, I basically say I'm going to use a surgery that's going to enhance their outflow and try to exploit their intact collector system if they have one. And that's what we're going to focus on today, which is essentially angle surgery. Now, just the basic pearls for someone who's never done angle surgery, you have to understand angle anatomy. And the only way to understand that is to practice. And that's intraoperative gonioscopy, but even before that, that's clinical gonioscopy. So I would basically say use a gonioprism in clinic as often as you can. Any chance you can to do gonioscopy, you need to do it, because the more normal variations you see, the more you'll appreciate normal from abnormal. Once you feel comfortable with clinical gonioscopy and clinical angle anatomy, then you need to understand how it feels to be in the angle in the surgery. So essentially, I guess the best first step would be after just a straightforward cataract surgery. You're sitting temporal, the lens is in the IOL is in the bag, and the eye still has viscoelastic in the eye. At that time, just turn the patient's head away from you, turn the scope towards you, and just put the gonioprism on the eye and just look. And do that a few times and kind of move it around and kind of get a good sense of how it feels just to perform intraoperative gonioscopy. Once you do that a few times, then just get your second instrument and put it in the eye and get a sense of that tactile feedback of what it's like to be within the eye. Do that many times first before you consider performing any angle surgery. When you are performing angle surgery, I'd say some of the ones that have a lower threshold for entry would be the goniotomy procedures, either the Tonito blade or a KDB, or maybe like a hemi-GAT before you try to move on to some more involved angle surgeries. You mean always have a good view, so you can see this gonio picture right here. There's a little water stain right here that can mess up your view, so make sure you clean off the surface of it. And then when my assistant hands me my gonio prism, you can see I have Helon underneath on the surface, and I have Helon on the eye. Both of those help really maintain an optimal view. You need to be gentle. This is not orthopedic surgery. This is microsurgery, so be gentle. Don't do a lot of pressure on the eye. When you make your paracentesis, try to avoid any blood vessels. And if you can't see, you need to stop and put in Helon, reform the eye, and then continue. If you have the option when you're performing a couple of cases, try to perform it in a pseudophakic patient. You need to maintain the chamber at all times. I like to use Helon GV. It's not a race. Take your time. There's no need to rush. And I always have all my patients in reverse Trendelenburg. So this is this is a real view of the picture of a patient in my operating room. But I always have them on their back, obviously, with their head above their heart. And that actually is the difference between these two views. Is minimizing episcleral venous pressure, maintaining the chamber, and that's the difference between blood reflux and no blood reflux. You also need to be comfortable, so make sure your posture is appropriate, make sure your hands are comfortable, lower your shoulders, keep your head straight, keep your neck straight, scope tilted towards you, patient's head tilted away from you. You need to make sure you're comfortable. Now, there's a difference in the view from kind of an above view or a head-on view or an en-face view. And this is courtesy of one of my colleagues and friends, Hadi Saab from Canada. But you can basically see the difference between if you're looking up above, that's on the left side, you're more likely to go straight down and create a dialysis cleft, as opposed to if you're looking en face, then if you're more likely to get into the canal, and it's a much safer procedure. And that's all about just tilting the head appropriately, tilting the scope appropriately, and not rushing and waiting until you have the optimum view before you move on. Now I'm going to try to show a couple examples of, this is just me looking back and forth into the operating room, and that's a head-on. And then you're going to see I'm going to move the eye just a little bit, and you're going to get an en-face view. So in this example, I'm going back and forth between an appropriate view and an inappropriate view, so you can appreciate the subtleties of a head-on view versus an en-face view. So that's a little bit of a head-on view, and then just with some subtle movements. And again, you can tilt the head, or when you're in the eye, you can actually move the eye a little bit to get more of an en-face view. There it is. That's a big difference between those two views, and it's subtle, but it's important. So first thing I'm going to talk about is this tenedo goniotomy, and actually. This comes out of India. It's one of the first really prospective randomized trials comparing goniotomy with phaco alone, or phaco goniotomy and phaco, and showed in the phaco tenedo group a sustained and significant drop in pressure and medications at 12 months compared to the control arm, which is a phaco alone group. And while the tenedo group, the tenedo goniotomy group, had a slightly higher risk of hyphema, the phaco group had more common spikes in pressure afterwards. And this is the tenedo blade. The reason why I like it is I feel like it's a little easier to use. It's reusable, so it's cost effective, and it is effective as well. And there have been many studies showing that. So here's a video of the tenedo, performing the tenedo goniotomy, and then also demonstrating the episcleral venous fluid wave, which is intraoperative confirmation of intact outflow. So as you can see, I have Helon on the eye, Helon on my gonio prism, and I'm using the instrument to kind of maybe even adjust the positioning of the eye a little bit. And there's a left and a right-handed version of this. So I start off with the left, get into the canal, and I perform a goniotomy to the left, and you can see the white strip. That's the back wall of Schlemm's canal. You can see a little bit of blood reflux. And then once I've treated the inferior portion appropriately, then I move to the superior portion with the, this is the right-handed tenedo blade. And again, the reason I'm not getting a lot of blood reflux is because I'm maintaining my chamber, and I have the patient in reverse Trendelenburg. Now, as far as the KDB goniotomy, I'm going to show kind of what the blade is. I think a lot of you are familiar with this now. It's a dual blade with two blades and a ramp, and it can also be used to perform a goniotomy successfully. And here's some still images where you have to kind of puncture the trabecular meshwork, get in, and then treat across. And you can still see the back wall of the canal. And here's a video of a KDB goniotomy. Again, in this situation, I'm going to kind of score one area and get in, and then I'm going to go back, and this is kind of so they're basically, I've isolated that section of the trabecular meshwork that I'm treating, and then I'm going to go meet that point that I initially started. Really with the hope of just performing an excision of that trabecular meshwork. And you can kind of see that back wall of Schlemm's canal and the trabecular shelf. And again, you can see a nice wave afterwards. And now you can see the same thing with the GAT, right? So a GAT is an ab internal 360 trabeculotomy performed with a suture. And this can be used obviously to treat 360 or even 180 if you wish, called the hemi-GAT. It's a blunted 5-0 proline suture. For the sake of time, I'm not going to show a video. These are the instruments I use for a GAT, be it a suture GAT or a catheter GAT. And as far as kind of more pearls for experienced surgeons after a GAT, when it's a right eye, I like to pass the suture counterclockwise. So, because if it's going to stop after going 270 degrees. So if you go counterclockwise with the right eye, it'll stop at 6 o'clock. If you need to retrieve it or you can see it, you can move to the head of the bed. And so for the right eye, I go counterclockwise. For the left eye, I go clockwise. I do leave a little bit of helon in the anterior chamber based on the amount of blood reflux that I see and the amount of the wave I see. So if I see a tremendous wave and a tremendous amount of blood reflux, I leave a decent amount, maybe 30, 40%. If it's a minimal wave, I won't leave any, or maybe 10% of helon. So I would say play with it when you're doing it and get a sense, err on the side of caution. Maybe lean more towards leaving no helon, or maybe 5 or 10%, 15% helon fill with a lot of blood reflux and a tremendous wave. If the suture stops, you actually, if you think you're in the right place, you can just gently pull on it, and it'll create an otomy, and then you can go the opposite direction, therefore treating 360 degrees. Now, obviously, the cost-wise, when you compare a suture versus a catheter, the cost of the suture is tremendously more favorable. It's also less likely to kink a little stronger, but the flashing light of the catheter is reassuring, and it can help you kind of see where you are. I tend to use the catheter when I'm doing my juvenile open-angle glaucoma patients or my primary congenital glaucoma patients. And these are kind of when I perform GAT. And I'll actually say on the more mild side, when you could consider doing a goniotomy. So mild to moderate glaucoma, secondary open-angle glaucomas, all stages. And these are people that have real disease, not the mild type of glaucoma. I don't do this in patients with very advanced glaucoma that have been on drops for a very long time, patients that need pressures of 12 on nothing, or that can't be taken off blood thinners, have an unstable IOL, or can't sleep with their head elevated for a couple weeks. This is my postoperative course. Antibiotic steroids, over the first month or two. Once the inflammation is gone, then you can taper the steroid. If the pressure goes up, the first thing I like to restart is pilocarpine. And then I'll consider a beta blocker and then a prostaglandin analog. If I do see a layered hyphema, probably 3 to 4 millimeter hyphema after 1 week, I do have a tendency to take them back and do a washout. And then there's some more evidence that topical NSAIDs are becoming more and more useful after angle surgery to get the patients off steroids as soon as you can. So just in general, when you're trying something new and you're trying to incorporate any surgery in your surgical armamentarium, be that angle surgery or suturing IOLs, one, you need to practice, control your variables, practice in the wet lab. Talk to your colleagues, watch videos, and then I always just sit down and draw out exactly what I'm doing in every step before I even get in the operating room. And then depending on the surgery, I will actually have a colleague that I trust come with me to the operating room and sit next to me and just watch, especially when I'm trying something that's never been done. Because they are there to watch while you're in the hot seat, and they can really help you innovate and come up with new ways of doing things. And then I also, I have an open door policy in my operating room. If any of you find yourself in the United States or in Dallas, please let me know, and you're welcome to join me in my operating room. So I'd like to again thank the AIOS for inviting me. Thank Dr. Venkatesh, Dr. Manoj, and Dr. Sushmita for reaching out to me and making this happen. And I'd also like to thank our distinct group of panelists. It's so good to see so many of my close friends involved in this program, and thank you for involving me, and I hope to be out there one day soon.
Right. So could we take a couple of questions, Dr. Venkatesh, since we seem to have the discussion time in between?
Yes, madam. Yeah, we can.
Yeah. So, Dr. Vanitha, I'd go on to you. When you have a patient in front of you, what are the factors that make you decide 1, 2, or 3? Which patient would you straight away say I'm going to put in 3 versus maybe a KDB or a GAT, because obviously the pressure lowering would be. So what would you make you decide?
See, 3 is not available, so that's out of the question at the moment. 1 also is actually going out of circulation pretty soon. Not much is available, but I do discuss the whole gamut, which is not a lot of MIGS that are available in India, and of course, I also have the capability of doing endocyclophotocoagulation. So in my angle closure eyes, that is actually usually my go-to procedure. But in every other situation where MIGS is appropriate, I do give them the option, and I believe that the first thing they ask me, of course, which one is the safest, and of course I have to say that the eye stent at the moment is the safest, and I think they go and speak to the surgical counselor, look at the price range, and then decide themselves. I really don't have much to do. I actually approach it with a lot of what shall I say? Well, actually, with no bias. I tell them that these are the procedures that are available, and that they would be suitable in your case, of course, along with cataract surgery. I'm trying to sell them a surgery that will hopefully eliminate their medication, and the data I've got is close to 80% or more, and of course in the process also control the pressure a little bit more.
Leon, are you there? Dr. Leon?
Yes, I'm here.
So, Hydrus, I know you're a Hydrus guy, but Hydrus versus KDB or GAT?
Well,
since you say Hydrus, so we're assuming that you're saying iStent doesn't work as well as the Hydrus does, but then
I'm not so sure. I mean, I think things keep changing. I think we'll have to wait for Conrad to see what he says. But yeah, I'm not entirely. I don't know. I think that my view have probably changed a little bit. I'm not a fan of ripping. Purely in terms of stenting versus ripping, I'm not a fan. And I think you've seen a great discussion about what he needs to do to get the GAT procedure. The patient needs to be this way, stop the anticoagulant, and I don't want to see any blood. I think so I'm not a fan of ripping, and I still don't think we understand the canal and the meshwork well enough to rip it. I think the meshwork is there for a reason, and I think ripping it, I don't know what it would do for the long term.
Okay, fair enough. I think we'll go on, and we'll put the ball in Conrad's court now and listen to you. And what do you say about what you think?
Good. I can give my presentation first, and then we go on with the discussion, right? Because I think it's getting really interesting. And right, let me share the screen. Here we are. And are you seeing my presentation?
Yes, it's visible. Please carry on, Conrad.
Okay, great. Well, this was the question that I had. The proposal of is Hydrus the ultimate MIGS. First of all, these are my disclosures, and no financial interest in any product that has relation with my presentation here. So if we go back to a little bit of the history we had, it's a very long history for the glaucoma. Since 1875, we have the pilocarpine, and in between all of these medications that probably were the first step that got into it, we got all the rest of these devices that were coming. Some of them stay longer, some of them disappear for different reasons. And as you can see, the Hydrus really was approved since 2018, but it was tested before. Since 2015, here in Saudi Arabia, was used by mainly Dr. David Craven. We implant some, and unfortunately, we don't have it now here. But well, Leon is a fan. In Europe, there is a lot of people using it. I use it in Europe. So this is mainly the things. So
when we have a large vademecum like this, what are we going to use? What are the choices we have? Some are related to the preferences, some are related to the effect we get. And of course, in each surgeon hands, there is a different experience. That's why the variety is so large. But most of these devices should try to get into the essence of the MIGS, which is minimally traumatic. And I like what Leon just mentioned. I don't like to rip the Schlemm canal either. I prefer to keep the membrane, and should be safe. And mainly MIGS move in between what we could consider the safetiest, which are the drops, but the most efficacious, that is the tubes. So in between, we have this large amount of devices that we can use. And Vanita said something that for me was very interesting. It's now we have the chance to do the surgery earlier. Until before the appearance of these devices, the options were limited. We have the trabeculectomies, we have the DS, the deep sclerectomy for those who likes, as myself, by the way. But the choices was, well, we all know the complications this major drainage surgery has. The target of these angular devices basically is getting here into the Schlemm canal filtration area, and we can have an indicator that is the reflux, as Leon mentioned. I prefer to see the blood because it guides me where I should go for the implantation. If I don't see any blood, I don't really know if that Schlemm canal, that and the behind collecting channels are really working. We need, in a way, we need to see if there is a kind of reflux when we decompress the eye. And a lot of the reasons why we fail is because we don't target the filtration area. Remember that we have in this angular area, there is a non-filtration area, and the main one that we want to target, that is the filtration area. And most of these devices, like iStent, like the Hydrus, are targeting the area that have a large amount of collection of collecting channels. And that's why we target the nasal area, superior and inferior. And even if this angiography that Vanita presented is not related to Hydrus, this is the main idea. If we are able to bypass the Schlemm canal by using any device like Hydrus or iStent, we're going to be able to communicate again, to restore again the natural way. And I believe that this is the step forward that we are taking now, especially the ones that are fans of the Schlemm canal surgery, which is trying to restore earlier the functioning of this area. Also, by improving this part, we are also going to be able to increase the flow into the aqueous veins. So we talk a lot about each personal algorithm. Well, I have this my own. At the beginning, I like to start with SLT, absolutely. Medication or SLT here in Saudi Arabia, there is a lot of movement into using medication because it seems to be easier, and there is in my idea, there is the wrong thought that the SLT doesn't work that well in Saudi Arabian patients. But when we see the proper diagnosis in which we are using the SLT works well. And absolutely, I don't like to go standalone devices, angular devices. So for me, it's all of these things. When we need to combine with phaco, it will be like the third step into the algorithm. What is the Hydrus specifically? Well, it's a flexible 8 millimeters long, so it's really here size matter. It's the largest probably device that we can insert into the Schlemm canal. It's made out of nitinol, which is an alloy of nickel and titanium, and it has been previously demonstrated in a lot of materials used in medicine that it's quite biocompatible. Once inside, it will enlarge the Schlemm canal 5 times the size. So it's a real enlargement. And I can understand why Leon liked this enlargement of the Schlem canal. And it also takes a whole quadrant, 3 hours. So if we are checking on eye stents in where we are going to implant it, and we have the chances of 1, 2, or 3, we probably are going to get a range of about 100 degrees as much separately. And this one going inside will almost get 90 degrees. It has been approved by FDA since 2018. And basically, most of the device is implanted inside. It's only the outside, the inlet is the one that will remain in the anterior chamber. This is a surgery from my colleague, Dr. Martinez de la Casa. I didn't have any new one, but he has a lot of experience on these surgeries, and he passed me this one. So you can see the insertion of the Hydrus. Sometimes get this little stuck, and you have to do a little movement until it's released. And this is a very nice implantation in the place that it should be. It went smooth. Why we approve why the FDA approved the Hydrus is based on the Horizon clinical trial, which evaluate a large number of patients with primary open-angle glaucoma, randomized 2-to-1, following phacoemulsification. 369 went with a microstent, and 187 went without. So at 24 months of evaluation, the mid-pressure drop in the Hydrus group about 31% versus 24% in the group of phacoemulsification alone. The medication reduction was also larger, and about 77% of the Hydrus group meet the decrease of pressure more than 20%. Compared with 57 from the non-device group. Most of the complications presented were hyphema and some peripheral anterior synechia, which seems not to affect that much the final pressure. Right now, the 3 and 5 years result of this Horizon study came out, and it also showed that there is a lower probability of incisional surgery in the group with the Hydrus, and also produce a lower rate of visual field progression, which is quite interesting, and demonstrating the efficacy of phacoemulsification plus Hydrus implant for preserving the vision and slowing the glaucoma progression. This is part of the conclusion. So now, what are the conditions that we have? Well, we have this pivotal inject iStent study at 36 months. If we compare with the Hydrus Horizon study, we can see that there is basically similar results regarding the medication-free, regarding the decrease of pressure, and the medication-free at the end. This is important because, as Vanita mentioned, iStent was probably the first device that generalized the use of angular surgery. And Holman studies comparing also the two devices had similar result regarding at 2 years, regarding the level of pressure, regarding the visual field stability. And some of the studies, like the Salima one at 3 years, show that the Hydrus microstent implantation had also this common reduction of pressure, preserve the visual acuity compared with the non-device implantation, has a stability regarding the structural and the function measured by cap-disc ratio, retinal nerve fiber layer thickness, ganglion cells, and visual field. It was presented last year in the American Society of Cataract and Refractive Surgery, the Schulz data, in which during the surgery, intraoperative, it was not adverse event in the iStent group, plus in the Hydrus, it was 2 postoperative adverse event, 1 device dislocation and 1 malposition, and 5 secondary surgical intervention was needed in the Hydrus group. You can think that basically as iStents are a simple maneuver compared with the Hydrus, it will be easier to have these dislocations and malposition. Antonio Fea also had a nice study in which he observed mainly this intraoperative reposition needed in two of the patients and obstruction in 1 of the patients. The thing here is that once you are trying to introduce, and I would like to hear Leon that has a lot of experience here with the Hydrus, reposition as it was shown, for example, by Vanita in one of the videos, when an iStent is not properly implanted, it can be easily removed and it can be easily reimplanted, or even if it's half away, it can be pushed. But the Hydrus is quite difficult to relocate it. And even if the extraction is possible, it really make a surgery not clean, not easy. It changed from a smooth surgery way into a quite complicated surgery, at least the ones that I had in such a situation. Another thing that I believe we have to pay attention is regarding the endothelial cell count. We all remember the CPAS. The CPAS at the beginning as a suprachoroidal device. It was, you know, like another way open, a totally different device and technique. And really the loss of endothelial cell count came a lot later. So the Hydrus in some of the studies, especially this one done by Ike Ahmed, show a little bit of loss of endothelial cell count when it was combined with phaco. It has a loss of about 20%. So it's something that at more than 5 years we will have to be paying attention. So how we make the device selection? Well, basically we have to take in consideration how good is this device in order to reduce medication, the safety of the device, the good control of the IOP, what is the long-term evidence, but not only regarding on medication-free, on decreasing of the pressure more than 20%, but also we have to take care of pay attention to how is the endothelial cell stability, the slowing visual field progression, and most of these surgeries, I believe, will get the good point of delaying the second surgery. Quality of life, it was mentioned by Leon. This is something very, very important. We have some studies done here in Saudi Arabia with another devices in which the quality of life in all of these patients that goes for phaco plus angular surgery improve the quality of life a lot. And in conditions, environmental conditions like here, which is very dry, decreasing all topical medication is a real advantage. And we are also going with what one of my fellows defined as the elite glaucoma treatment. We have to also target very little influence over the visual refraction at the end. So regard on a technique that we can rely on, that only the cataract surgery will influence the refraction and not the glaucoma surgery till now. Protecting the tissues and what is available in each one territory right now. So when we compare a lot of this evidence regarding the effect of the pressure, well, most of these angular techniques or MIGS technique will have a decreased effect around 30 to 40%. And in common, they will have not only that decrease of level of pressure, but also the decrease on the number of medication that can reach 75% to 80%, at least in 3 to 5 years of studies that we have right now. We have to keep an eye careful on endothelial cell count at similar outcomes. Probably my options will be choose the more simple technique in a way of simple and effective technique as a wise measure. So is Hydrus the ultimate mix? I will say no. I think that it's going to keep going. We should keep observing, especially the outcome in long-term IOP. It seems to be very good, very stable in the visual field long terms. Medication-free for the patient is quite high, as most of the angular surgery. But the only concern that I have is how it's going to be really the long-term endothelial cell count, basically. So thank you very much.
Thank you, Conrad. That was a wonderful overview. Dr. Venkatesh, any points for carrying on the discussion now?
I think we'll finish the last talk because that's
Okay.
a very important talk where Craig is going to give us an overview of what procedure will suit what kind of glaucoma between open angle, angle closure, and also secondary. And then finally, we'll have a discussion.
Okay.
Correct?
Hi, good morning. Can you hear me?
Perfectly, yeah.
Sounds good. I'll share my screen here. Let's see. Okay, great. Well, thank you so much for the privilege to be here to speak with all of you. I think since COVID, I've given maybe 3 or 4 AIOS talks, webinars. Hope one day to visit you in person. So I particularly enjoy this group. You are an innovative group, always challenging our thought processes in terms of what we do, and also putting to the forefront the idea of being cost effective. In full disclosure, I'm going to disclose to you that much of what I'm going to present is not necessarily cost effective yet. But I think it's in the spirit of innovation that we have to start somewhere. And as more widespread use of MIGS occurs, I think the cost will come down significantly for those of us who are practicing around the world. So these are my financial disclosures, some of which are relevant. Most of these have been ad hoc consulting appointments and some research funding for devices and current trials that we're conducting. So I can't talk about MIGS in my experience without talking about my mentor. Many of you remember dearly and fondly Alan Granda, who just passed away a little bit about 4 years ago. And Alan was really a giant in my heart and a giant in the field in terms of challenging our current paradigms. Alan always put the patient first, but was always looking for a better way all the way till the end of his career, looking for better ways to do things for patients that were safer and more effective and improve quality of life. So this is a wonderful graphic that was just recently published in Glaucoma Today of the surgical pipeline that we now have in 2024. It's a very busy slide. And as you can see, we have our traditional filtering bleb surgeries on the left, some of which could be considered minimally invasive bleb surgeries, a term that's been categorized as MIGS surgery. And also we have a number of devices that are available to us both for supraciliary as well as trabecular meshwork bypass. And now we're excited also about the era of non-invasive trabeculotomies through femtosecond laser. So much to be excited about for our field. We can see it, the excitement in our trainees and our fellows. And so I'm really happy to continue this conversation about MIGS in particular. So MIGS is really, I think, important, as it's been alluded to, is having that interventional mindset. And it's really the best of personalized medicine. We're customizing our treatments based on unique individual patient characteristics, as well as family history and all the other things that we typically gather to understand what a patient's risk for progression is. And ultimately, it's about treating patients before there's actual structural or functional damage. I think we're all encouraged now that we don't have to wait anymore. We can detect patients who are at high risk, and we can intervene before it's too late, before there's actual end organ damage. And risk stratification is key. And now we have a number of tools that can allow us to do that. Genetic testing is super helpful in terms of identifying patients who are very high risk. To date, there's 16 genes or gene locations that have been identified for POAG, 8 for primary angle closure glaucoma, as well as 2 for exfoliation syndrome. One current tool that I'm using that has changed my practice and has actually allowed me to perform more MIGS surgery than I did prior is the advent of serial home tonometry. This tool has been extremely elucidating in terms of identifying patients who are at high risk for progression based on IOP fluctuation. What does the future hold? Biomarkers and continuous IOP monitoring, I think, will change our field dramatically again and will allow MIGS to come to the forefront. So these are some of the tools that we're currently using. Here in the United States, and I think available worldwide, is the service by 23andMe. They have a glaucoma screening panel. They can help patients identify some of the risks they may have in terms of inheritable genes that they could either pass on or they currently have of their own. The iCare Home 2 is our current device that we have for home tonometry that we're using. Many of our patients consider this to be useful information in order to better manage their disease and also to provide them reassurance that their treatment is working. On the right, and this is just one of many, this is what we currently use at our center, is the virtual field. And in some cases, we are sending some patients home with these devices to be able to monitor their own disease. They'll be renting the device and then they'll return the device. And so it's helped improve our patient management in terms of being able to see more patients and allowing patients to manage their disease and empower them. So these are some of the strongest risk factors that have been identified for glaucoma. This was a nice review by Doug Ree et al. And as you can see on the left, the risk factors for progression, risk factors for blindness in the middle column, and then risk factors that have been identified in every major disease. And one of the ones that I wanted to focus on is this diurnal IOP fluctuations. And we have some great studies, both AIOS as well as CIGIT study. And in AIOS, it showed us that there were major factors that influence progression: age, the number of glaucoma interventions, longer follow-up, and the big one was IOP fluctuation. And IOP fluctuation was defined as the standard deviation. And there was a 30% risk for progression for every 1 millimeter in increased IOP fluctuation. CIGITs also showed us something similar in terms of IOP fluctuation. Again, these were the risk factors identified for progression in this large study. And IOP fluctuation, defined as the range, was important in terms of predicting risk for progression. And in fact, if your IOP ranged by more than 8.5 points or more, your risk of progression was 96% over the 7-year follow-up period. So here's a patient of mine. This is Gary. This is Gary pre-intervention. As you can see here in his home tonometry graph, he had a Tmax of 26 in each eye and a minimum of 10. So that's an IOP fluctuation range of 16. This is his post-intervention study. And as you can see here, his IOP Tmax has now decreased from 26 down to 17 with a minimum of 8. So dramatically reducing his IOP fluctuation. So my task was been to talk about what type of MIGS would I choose for certain procedures or certain conditions. And a lot of this has already been covered by my colleagues that have spoken already, but just some of the things that I think about as I'm dealing with patients with different types of glaucoma. You know, I think for POAG, we have lots of choices, and I think it all depends on what you feel comfortable with, what you have access to, and also what may be cost effective for your healthcare system. We're fortunate where we are, where we have a number of options, and largely what drives this discussion, I think, is based on surgeon preference, as well as what is covered by insurance. You may have heard that there was a lot of discussion recently by many Medicare contractors that were debating the utility and whether or not they would reimburse for different types of MIGS procedures. Many of us were worried about this, that it would stifle innovation and also stifle our ability to choose what's best for each patient. that was recently put to bed, but it could reemerge again in terms of the discussion here in the United States because of our increasing healthcare dollars that are spent and also the expenses incurred. But I think over time, as we continue to do research on MIGS, we will show that some of these choices may actually be cost effective in the long run. We just don't have data. We're in that early phase or second early phase of the MIGS renaissance. But really, I think all of us would agree that MIGS in general is best for patients in the mild to moderate spectrum. And for patients that have advanced disease, that have significant visual field parametric damage, that this may not be the suitable choice for them. MIGS for primary angle closure glaucoma. I think we were all blessed with the data that came out from the EAGLE study that showed that early phaco is key, which is probably worldwide the most common procedure that we do for glaucoma is phaco. And particularly for angle closure glaucoma, early phaco is key. Added to that is GSL to remove any early synechia with the addition of goniotomy. I think could be incredibly useful to reduce the burden of patients who may need incisional surgery for angle closure glaucoma. For secondary open angle glaucoma, this is where I have the most experience. We have a very large population of pseudoexfoliation glaucoma patients here in the Salt Lake City area in the Intermountain region. And for me, the procedure of choice is really the phaco ABIC Hydrus. And I'll show you a little bit of our data, our data that we're hoping to publish soon in terms of ABIC Hydrus versus ABIC alone. Some new tools that are helpful for us now as MIGS surgeons. Many of us are familiar with the gonio prism that we use either left-handed or right-handed. This is one that I've been recently using for select cases when I may need to go in either direction. And this is the one by Oculus called the Gonio Ready. It is adapted to your microscope. It's attached in a biome style fashion. And here you can just drop down the gonio prism onto the surface of the eye and be in clear focus and be able to use both hands to be able to allow you to either manipulate a patient's eye, or sometimes you may need to clear blood and have to inject viscoelastic while you have the device in your hand. So it's nice to be able to have both hands free now for MIGS surgery. So here is our data looking at the Hydrus versus ABIC Hydrus alone. And as you can see, when we get out to 12 months, which I think is probably the most pertinent, is we can see a nearly 1 point difference in the combination of Hydrus and ABIC versus Hydrus alone. And is 1 point even helpful? Yes, I would say that even shooting for an improvement of 1 point difference, any point that we can have in terms of pressure lowering is helpful to mitigate against further progression, as we can see from the IOP fluctuation studies from SIGITs. Again, if your IOP fluctuated by more than 8.5 points or more, your risk of progression was 96%. So anything we can do that's additive in order to reduce that IOP fluctuation, I believe is helpful for reducing long-term progression. So now we're going to end with just, this is my favorite MIGS. This is the one that I perform a lot for patients. And this is really the triple procedure of my practice. And here, this is my fellow performing the procedure. And so I have found that for early MIGS surgeons, and even for me myself, I particularly enjoy having reference marks to know where I am in space. Sometimes when you put the gonio prism down, it may be difficult to see where you are for landmarks. So I typically mark the nasal junction, and then I mark my paracentesis sites. So it's nice to know where they are while the gonio prism is still on the surface of the eye. And it's always nice not to have to create any epithelial abrasions, corneal epithelial abrasions. So we're starting with our main incisions. Now we've turned the head. This is the gonio radio view that we can see the NFOS view of this patient. There's a little bit of heme under the gonio prism from just the limbal vessels. This patient had particularly injected limbal areas. We've now created an MVR, small little goniotomy cleft. And what I'll be introducing next is the iTrack Advanced device. This device allows continuous both dilation and cannulation of the canal. And this can be done with the device. Previously with the iTrack Advanced Original, we were having to do this manually with a microforceps. And as you can see in this video, what I'm showing to you is that the catheter is getting stuck roughly about 3 clock hours from the original entry site. We're trying to manipulate this area, trying to massage the catheter to be able to continue in the Schlemmer's canal pathway without diving down a collector channel or an aberrant pathway, but unfortunately, it wasn't successful. So what we're going to do now is we're going to switch our hands. This device allows you to go in either direction. And the nice thing now is we can use the device to cannulate all the way around in the opposite direction. And here we're successfully able to cannulate around 360 degrees. We've learned so much from cannulation of the Schlemm's canal by understanding that there are one-way valves, there are septae, there are things that may actually prevent us from actually proceeding around for the entire 360 degrees. And as we reverse this catheter, you can see that nice blanching pattern. We're able to inject viscoelastic into the canal to fully dilate the canal. For me, this is extremely helpful to identify areas that are dormant and areas that may not be functional. And so I like to titrate and place the Hydrus in the direction of where I see the most blanching. And now we'll go ahead and position this Hydrus. And as was alluded to, there may be a higher endothelial cell count risk for the Hydrus, but I feel that that's with malposition of the Hydrus. I really feel that this needs to be deeply inset into the Schlemm's canal. What I was showing you there briefly was just inspecting to make sure the entire Hydrus is in the canal. You don't want to have any of the windows missing. And so for me, I will explant a Hydrus if all three windows are not showing inside of the canal using intraoperative gonioscopy. We're proceeding with phaco here, cortical removal. And as you can see throughout this case, there's significant blanching for nearly 360 degrees. And this remains throughout the entirety of the case. And as we know, some of this may resolve over time as the viscoelastic dissipates. But what we can see here is we're encouraged that there are still multiple areas that are patent in this patient that are connected to the anterior chamber. And if we can just access those points, we can better optimize a patient's outflow system. So this for me is my favorite procedure that I perform, which is the triple phaco ABIC Hydrus. Thank you so much for your time, and I'm looking forward to hearing the rest of the presentations and engaging in the discussion.
Thank you, Greg. Yes, Dr. Sushmita, I think we can start the discussion. I mean, we can start with somebody who has not had an opportunity to speak now. Yeah.
Yes. So Swati, your take. We know you're a wonderful GAT surgeon, wonderful upcoming. Swati is with Dr. Venkatesh, I think, in Pondicherry. But given a choice, like Leon said, he wouldn't like to strip. And if you had a choice of all the devices, let's not say that it's not available in India. Scientifically, what would you do and in which patient?
Thank you, ma'am. Thank you, AIOC, for giving me this opportunity. And I'm really, really happy to have seen all such beautiful surgeries today. So, my take home is like, I will consider the age of the patient, the number of medications the patient is on, the severity of glaucoma, and the expectation from the patient. So, from our personal experience, we had a patient with advanced glaucoma where we injected 3 iStent injects. And the third iStent inject was like by courtesy from Glaucos that, okay, fine, because I was not sure whether it is over implanted. So they gave me the third, and the patient is off the medication. She was on 5 medications pre-op, and now she's off the medications, and it's been 1 year down the line that she's. So more iStent injects, more IOP reduction, I agree. Regarding GAT, yes, I have been doing GAT, still I do, and there have been only 2 patients among my around 80 patients that I have done that they have gone for a AC wash. So it's not such a big problem with hyphema. And still, yes, if the patient is on 4 medications, I would like to be a more aggressive, and I would like to do a GAT. If the patient is a normal tension glaucoma patient on 1 medication, I just want to take the patient off the medication, I would offer the patient the opportunity to select from KDB if the patient is affording. And if the patient is not affording, then we are a big fan of bank. So we do bank also. And KDB is, yes, in our setup, being a hospital, like charity hospital more so. So if the patient can afford, if they have insurance, we do offer, but not so many can bear the cost of iStent inject.
Would you do any of these procedures if you were not doing the cataract surgery with a clear lens?
Yeah. So we have a patient who is a VVIP, and then he has got very advanced glaucoma. He's monocular, and we have done iStent inject in that standalone. So, and he is pretty much, he is down from 4 medication to 1 medication. And he has not developed cataract also so far. So, and also there is a patient who has glaucoma in pseudophakia. So we have done standalone iStent inject in that patient also. There is a boy with traumatic glaucoma. He's healthy disc, everything, but he was on 3 medications. We did KDB glide for that patient. He's also off the medication now. So it does work, but yet combined with cataract surgery, the drop will be more.
So, Dr. Ganesh, I'll take it to you. The one thing that our ears pricked up was one-eyed advanced glaucoma. Your choice would be an iStent inject. Dr. Ganesh, of course, is also in the Arvind Eye Care in Madurai.
I'm in Coimbatore.
Oh,
Yeah.
Coimbatore, sorry, yeah. So your take on a patient who is monocular advanced glaucoma.
Yeah, I think I'll start by saying a disclaimer. I do a lot of SLTs, number one, for mild glaucomas, and do a lot of ab external canaloplasties, So having known that, I would always juggle between all these three, stenting it or stripping it or even doing ab external canaloplasty. So for a situation like this, I play it safe with ab external canaloplasty. But having said that, if you're just talking about MIGS, I would really prefer to stent it before, if I have the ability, or if insurance is not a big concern. If I have the device, I would prefer to try to stent it. And then, of course, you could always go back again. And even if you want to do a major excisional goniotomy, you could do that as well.
Okay, maybe I'll take it on to the gray hair. Dr. Venkatesh, uniocular advanced glaucoma, uncontrolled trap wouldn't be part of our thing, the situation?
I would still do a trap. Yeah,
I would do a trap too. I mean, I think it's gray hair, but
no, I would.
I'll leave it open to all panelists. Uniocular, one-eyed, because that's the message that we want to send out. That a uniocular, one-eyed patient, uncontrolled glaucoma should not be your top of the list for MIGS. I mean, that's what I think. And I would like to take this across. Leon.
I 100% agree. And I think that's probably a misconception that MIGS surgeons just do MIGS all the time. And I agree that I can't remember many situations where MIGS got me out of doing a trap. When they need a trap, I'll do a trap. And that is still all of our number one procedure. And we must remember that very well. And I think like what, uniocular, when the stakes is high, then I do a trap. And everybody must do a very, very good trabeculectomy. There may be occasion where the eye is not ready for a trap. For example, there are multiple medications that they're on 4 or 5 meds and the eye is red. Then I think there is a place. And I think that's probably where some of the surgeons have done, put a MIGS in, shoot an iStent in, and then allow them to reduce medication for a few months and go for it. But I would not rip a meshwork because I'll be worried about what if next, then the eye is full of blood, your pressure is 35, then you are in a worse situation. So yes, I would pick a MIGS to buy me time if buying time is what you need, and I'll pick the safest MIGS, which will be a stenting procedure.
Jitin, your quick thoughts on this? I mean, you are a fellow of Ike Ahmed, and you have been doing now all these procedures for 3-4 years.
Yeah, so if you're talking about the specific case where it's a monocular patient with advanced disease, I think most likely some sort of bleb forming procedure is going to be the way to go. And I think my choice of which bleb forming procedure depends on what my target IOP is, like where do I want the patient's pressures to live, and what is my pre-operative risk assessment that there'll be someone that's scarring. So in the US, we have like a large array of patients from different ethnic groups that we take care of. And for instance, if you have an 89-year-old or 90-year-old Caucasian female, and her pressure is in the low 20s, and my target pressure for her is to get below 15 consistently, I think a Zen is a very reasonable option in that type of patient, a micro stent with lots of mitomycin and a 30-gauge needle track to reduce the risk of perioperative flow. Instead, if I have an African-American patient or a darker skinned patient whose pressures are 18 and they're progressing at that level, then I want their pressure probably closer to 12 or 13. And I think in that case, a trabeculectomy is very, very, very reasonable. So there are a lot of different factors to consider before selecting the device. In those patients, I generally would not do an iStent or a MIGS device unless they're very close to their target pressure, like maybe a couple of points from their target pressure, and I need to drop them from 17 to 15 or something, and they're willing to use medications afterwards. So if I am doing a MIGS, an angle-based MIGS procedure, I would definitely inform them beforehand that you will need a medication to get to your target, and you will have a high risk of needing a second surgery if this doesn't work.
Right. Dr. Vanita wants, yeah.
Yes, thank you. Well, actually, I would do a combined MIGS. I would do an inflow procedure, which is ECP, and I would do an outflow procedure, which could be anything, which could be a bang, which could be a KDB, or it could be a stent as well. And believe you me, not only are these eyes very safe, they recover very fast, and the pressure reduction, unbelievable. I can actually quote you my figures, again, unpublished, but I'm going to publish them pretty soon, is from a pressure, preoperative pressure of close to 19 in a very advanced glaucoma who are either progressing or, cannot tolerate medication or whatever and don't want any more medications. So starting with a pressure of close to 19, medication close to 3, I have managed to drop them to a pressure of 12 and medication to 0.5. I think I have achieved my target. Not only are these eyes safe, you say trab in an only eye, I worry. If they go away, what happens to that eye? At least from this point of view, I'm not creating a bleb. I'm not creating a bleb that I cannot oversee for the rest of my life. I do get a lot of patients from all over the country and actually international patients as well. And I'm always worried that, if I do a trab and I can't follow it up, the patient's only eye might suffer.
So just a caveat to that, if the patient was phakic, would you wouldn't have ECP in your...
So we're talking about an adult patient, okay? So, a little bit of cataract is always there. Yes, I wouldn't do in a phakic patient. In fact, my absolute indication of trab these days is the young JOAG where I cannot take the lens out, or, the young adult who still has accommodation. So I wouldn't take the lens out in that. But, if it's a angle closure patient, POAG patient, you do any procedure, you will, in trabs, you have a 30% risk of developing cataract. So, I motivate them. If there is early cataract, get the cataract out, control your pressure.
Right. Dr. Craig, an early OHT, MIGS versus SLT, how would you make the choice? Phakic? Mild?
Phakic, yeah, SLT for sure. I think we have lots of good data, and SLT is going to get even easier to perform. And I think it's an unmet need. I think there are a lot of patients who would benefit from SLT, but it is somewhat time consuming if in terms of the technical portion of performing the procedure. But there'll be some new advances, and there are already new advances from the Belkin company to make SLT even faster and more efficacious.
Yeah, so the message of the advanced glaucoma requiring a bleb forming rather than when you have single-digit requirements or even early double-digit requirements, and phakic patients, maybe SLT is a fair choice rather than going in for surgery. So the idea is not to take the message out that just because MIGS is available, every patient or with even mild glaucoma is a MIGS candidate. Dr. Venkatesh, on to you. I'm not sure how much time we have.
Yeah, we have 5 more minutes.
5
Yeah.
minutes. Okay, so take it on.
So correct. I mean, you are mentioning about combining these two techniques, right? Do you do any other combination like that? Maybe a KDB with a stent or something like that? Is it being happening or?
I have a few patients that I've performed a goniotomy plus a stent. Those are for pigment dispersion glaucoma. In that particular pathology, I feel like the pigment is the overwhelming problem. But at the same time, I'd like to try to optimize the goniotomy long term in case there's a portion of it that tends to close. So while there, why not put a stent in? So prior, when we had G1, we were doing goniotomies and placing 2 iStent G1s, one in either direction on the end of the cleft. Now with the Hydrus, I typically just put a Hydrus in as long as it fits well and I can ensure that it's seated well. Again, if I feel like it's malpositioned, I'll just remove it. And then we don't have any G1s left in our consignment. And so I'm not able to perform the original G1. You could do a G2 with the iStent Inject W, but I just felt like it worked well when you were able to put the G1 at the end of each cleft.
Yeah. So I think we can debate for a whole day on ripping versus resting a device. But unfortunately, in a country like India or even other developing world, now still these devices are very expensive. Some are covered by insurance, some may not. So, I mean, starting from Jitin and then Leon, what is your thoughts? I mean, we don't have to debate between these two. At least, what is your thoughts on this and how we can take it forward?
Yeah, so I think unfortunately we don't have a lot of very good comparative clinical trial data comparing ripping versus stenting. I mean, for me personally, how I make the decision is based on the visual field results of the Horizon trial. And so, you know, I think the Hydrus is the only device we have that shows that at 5 years, we can actually reduce the risk of visual field progression and reduce the number of rapidly progressing patients. You know, if the iStent had similar data or if goniotomy had similar data, you know, I'd be more inclined to use that in my, you know, cataract plus glaucoma patients. But if I had to make the choice, then I go with the stenting procedures, particularly the Hydrus, because they have the most data to back them up. But I can very much understand that for cost reasons, that the goniotomy procedures are very reasonable, and they may work just as well. We just don't know. We just don't know in a head-to-head fashion.
Leon,
yeah, no, I it's not much of a debate really. If you don't have it, you don't have it. But yeah. So I agree that you do what you can do, and so rip the mesh work, and I think that a KDB, a goniotome versus a bang, I can only assume that they all work the same, and a GAT, a suture versus a cannula, they work the same. So yes, so I think then, you know, you're already using what economically is available to you, and ultimately the result is probably not hugely different. I don't know what the long-term stands, but the stenting is got a lower complication, and I think those will play in favor in some patients.
For people who are doing a GAT using both the catheter and suture, what do you feel is an ideal? Is it the catheter or the suture? People who have done GAT with both these. Greg, you have any experience on that?
Yeah, so you know, when I first returned back to the University of Utah about 11 years ago, really the dominant player in our MIGS portfolio was the GAT technique. And I did a lot. I did a lot with suture and I did a lot with the catheter. I'm in a training institution, and I would say for me, it was also very helpful to reduce the amount of bleeding with the catheter, because you could dilate on the way in and completely fill up Schlemm's canal with viscoelastic, and then you could then finish the stripping portion. And so we didn't have a lot of bleeding when we used the catheter. But then when we started using a lot of the suture technique, we had to keep some of these pearls that Devinder has alluded to, making sure the patient was in reverse Trendelenburg, keeping the eye well pressurized, and making sure that patients were maintaining or reducing their activity level postoperatively. But with the catheter itself, I had very little bleeding as we were dilating on the way in.
Can I make a comment that I get talked about quite a lot, and I've got lots of friends and colleagues who loves it, and all the tips that's been offered has been great. But when you start applying everybody else, I'm going to have to make sure that everybody's aware that leaving viscoelastic in the anterior chamber in a glaucoma patient can be very problematic. So in terms of saying that we leave a little bit when got a little bit of reflux, and we leave a lot when there's a lot of reflux, and have to just everybody be cautious about it. Blood and viscoelastic equals pressure spike and terrible problem. So you have to be experienced enough to do that. And I just want to make that message very clear.
Yeah, and I want to just add something.
Go ahead.
Go ahead. Oh, I was just going to say, I want to add something. So I virtually never leave viscoelastic in my goniotomy procedures. Essentially what I do is I inflate the anterior chamber and I get the eye very firm at the end of surgery and kind of wait a couple of minutes and look for bleeding. And in general, leaving them firm and even checking that pressure the same day, I haven't had too many bleeds in my gap patients or in my goniotomy patients. Maybe one or two bad ones over the hundreds that I can kind of remember using that technique. So it's not necessary to leave viscoelastic. Just hydrate the wounds, leave the eye very firm, check for bleeding in the OR, maybe wait a couple of minutes at the end of the case, and then see them that same day for a pressure check. I think that's a very reasonable option.
Yes, Greg, last 10 seconds.
No,
Yeah.
I was going to mention that, Leon, that was my fear before. I do a fair bit of pediatric glaucoma too. And I was always concerned about leaving viscoelastic, but I think it also depends on the type of viscoelastic and how much you're leaving behind. So I very much, for a lot of my pediatric patients, leave a 30 to 40% fill, but it has to be a cohesive viscoelastic. And I'm always surprised how when you rapidly decompress these patients with a gap type of procedure, even leaving viscoelastic behind, they don't have a big pressure spike. It can happen, you're right, but I think it also depends on the type of viscoelastic. If you're using something like Helon GV or Helon 5 in the anterior chamber, I think you're asking for problems. But something that's relatively mildly cohesive, I think is actually reasonable to prevent that rapid decompression that leads to a large hyphema.
Okay, thank you. I think it's time now. I mean, I take this opportunity again on behalf of AIOC and the IOC, thanking each one of the panelists and also speakers today. And I'm sure this session has got a very good audience watching. The tech team knows about the numbers. Any idea, Prashad, before we close?
Sir, the actual numbers will be put out later, but I'm so sure that the current live viewership will be around 500 to 800 for now, and then it escalates to a few thousands.
Thank you. Thank you. And appreciate that. I'm sure once this is uploaded on social media, I'm sure there will be a lot of views. Thank you again. And like what Craig was saying, welcome to India. I'm sure we are seeing you quite often on the Zoom links, but definitely you're most welcome. Thank you. Thank you all.
Thank you
all for the wonderful
everyone.